right, good afternoon everyone, and welcome to the November 21st lecture from the WRTC, Western Regional Training Centre, on developing and sustaining a community-based participatory research program in rural dementia care. And we're excited to welcome Dr. Debra Morgan to present to us today. She is a professor at the Canadian Centre for Health and Safety in Agriculture here at the University of Saskatchewan. She holds a chair in rural health delivery and a CIHR SHRF Applied Chair in Health Services and Policy Research titled Healthcare Delivery Across the Continuum for Rural and Remote Seniors with Dementia. She leads the Rural Dementia Action Research Team, which we have 2 members here today, which is good. And she's been conducting a program of research focusing on rural and remote dementia care for over a decade, including a community-based care and institution-based care. She was the principal investigator of a new emerging team funded by CIHR and provincial partners titled Strategies to Improve the Care of Persons with Dementia in Rural Areas. That leads to the development of the Rural and Remote Memory Clinic, now funded by the Ministry of Health in Saskatchewan, I believe. She is co-lead of Team 20, Issues in Dementia Care in Rural and Indigenous Populations, in the recently funded CIHR Canadian Consortium in Neurodegeneration and Aging. Within the CCNA, the RADAR, the RADAR, team will focus on developing and scaling up strategies for rural community-based primary health care for individuals with dementia and their caregivers. So let's give a warm welcome to Dr. Debra Morgan to present today.
Thank you. Thanks, everyone. Thank you for the introduction and the invitation, Lisa. It's really great to be here and nice to meet all the students. And I'd just like to introduce Dr. Julie Kosniuk, a team member from RADAR, and our honorary team member, Danielle Ellis, our research coordinator. Today I'm going to be giving an overview of our research program. Some background about our team and a little bit of literature and theory about community-based research so that you can link what we're doing to that. And then as I'm talking about our research program over the years, I'll be embedding some of our community-based work in there, some of the strategies, some of the benefits and challenges that we've experienced over the years, and then just ending with a little bit about future directions. Okay. So I'm sure many of you know about dementia, but just by way of background, dementia is an irreversible loss of intellectual ability that's severe enough to interfere with everyday activities. And Alzheimer's disease is the main cause of dementia, but there's also other subtypes that are listed here that are less common. But getting a differential diagnosis can be challenging. Dementia is really itself is not a diagnosis, it's more of a syndrome, and it can be caused by different diseases. So identifying what the cause is challenging, but really important for treatment and providing support to the patient and the family after diagnosis. And we're learning a lot about the social and economic impacts of dementia. Internationally, dementia is being recognized as a tremendous global problem, socially and economically. And the World Health Organization came out with a document in 2012 declaring dementia a public health priority. Alzheimer's Disease International publishes every year a document. Last year, in support of the G7 Dementia Summit, they did an update on prevalence and incidence of dementia and estimates going forward. And they believe there's about 44 million people worldwide right now with dementia, and that's going to nearly double by 2030. So Canada is the only G7 country that doesn't have a national dementia plan or a strategy. But last month, Minister Ambrose announced that Canada will be developing a plan. I imagine it'll take a while, but it will happen. While waiting for that, the Alzheimer's Society of Canada, which has been lobbying for a national plan, took the lead and released the Rising Tide report in 2010 as really a call to action. And they wanted to provide evidence-based information on the incidence and prevalence and economic impact if nothing is done. And they proposed some strategies that could be used to plan and be prepared. They estimated then that in 2008 there were 500,000 people with dementia in Canada, and that will likely double or more by 2038. So, does anybody here know anybody with dementia? Do you have neighbors, family, friends? Yeah. Any ideas why caring for people with dementia in a rural area might be more difficult than, say, in a city?
Access to services, like
Yeah.
distance.
Yeah.
Okay. Yeah, access to services, just like the distances that you'd have to travel, and I guess taking the person with dementia out of their home, and that's a challenge in itself.
Those are really good points. Anybody else? Yeah, access is a huge challenge to, right across the continuum from diagnosis to management and long-term care. Access to appropriate services is a big issue. And we don't think that living in a rural area is actually a risk factor for getting dementia, but age is. And our rural communities are older. The 2011 census found that seniors made up 14% of cities, but 21% of towns and villages. So we have more people that are older, and it's mainly due to outmigration of younger people. And so we have more older people at risk for dementia, but less access to services in rural areas, and a lot of challenges in delivering services. So this is just an overview of our research program starting in 2003, and I'm going to be kind of going through this and telling you about how we've used a community-based approach and how it started. We've had continuous CIHR and SURE funding since 2003, and obviously that's very important for a research program, but it's really important for a community-based approach because once you engage with your partners and decision makers, you want to be able to sustain those relationships. And if you don't have funding to do it, it's harder. There is a cost involved with staying in touch with people, having them come to your meetings, you going to them. That all costs money, and having resources to do that is really key. So the radar name we came up with, I don't know how many years ago, 4 or something like that maybe. We were the NET team for a long time because our first main grant from CIHR was a new emerging team grant. And so we called ourselves the NET team for a long time. But eventually when that 5 years of funding ended, we realized that we needed to have a different name and something more descriptive. And radar, because of our community-based approach, which always involves an action component, we felt this name was a good one for us. And also the radar concept of identifying and staying connected with people with dementia and their families and caregivers and other researchers that are out there seemed like a good analogy. So we're radar. Oops. When we got our first team grant, we needed a conceptual framework, and so we came up with this, and actually it still works for us. It still informs what we do. We're interested in dementia from early to late stage, and then on the horizontal from the community to institution or long-term based care. And then from diagnosis and assessment in the early stages to implementing best practices all across the care continuum to more late stage and focusing on continuity of care and addressing availability, accessibility, and acceptability, and then overarching concepts of research and mentoring and knowledge exchange. Where am I supposed to point this thing? Okay, so this is our team, and I'm not going to list everybody. You can see the names there. I'll just point out that we have team members from 4 provinces in the UK, and we have a lot of different disciplines and expertise involved, including a lot of health, as you can see, but also geography, health economics. We have family caregiver, health region administration. So these are the co-investigators on our current grant. So I'll give you a little bit of background about our team and our research. So actually, I started as a postdoctoral fellow in 1997, and I had the great fortune of working with Dr. Karen Semchuk in nursing, and she introduced me to the idea of community-based participatory research, and that's where it started. She really supported me in learning how to do this and introducing me. And I traveled, there were 30 health districts at that time. There's now 10 regions, fortunately, but at that time there were 30 districts, and I met with all of those boards, so I got to know Saskatchewan quite well. And then we held a study day in Saskatoon with representations from all those districts to talk about priorities in rural dementia care and design a study. And one of the things that came out of this process was that we looked at community-based care in addition to facility-based. My background was in long-term care research, looking at the influence of long-term care, special care units on the behavior of people with dementia. So we heard very clearly that the community-based care was equally important to long-term care, and that's informed our research program, since then. So it was very foundational, this work I did as a postdoc. And then in 2003 was when our team, as it currently is, came together. We've had some changes over time and additions, but really quite stable, actually. And we had annual retreats for many years until we started having our dementia summits, where we bring together our decision maker advisory council, and I'll tell you more about that. But you'll see lots of pictures with summit on it. And these were the requirements for the NET grants, and community-based participatory approach was not in there, but we as a team felt it was really critical. Even though at that time CIHR didn't require that approach, our team felt that in terms of relevance, ensuring relevance of our research and building capacity in rural communities, that we needed to do that. What we call flagship project of the NET grant was the development and implementation evaluation of the rural and remote memory clinic. And there's a little video on our website, a little 4-minute video that you can look at. So I'll be coming back to that, but I want to sort of give you the big picture of our program first. Then when the NET grant ended in 2009, we were funded through an applied chair through SHRF and CIHR. And it just allowed us to continue that momentum. Like 5 years, really, you're just getting going. So we're really glad to have this funding to keep us going up until the present. And this chair, CIHR, did require decision maker involvement early and often in the research process, was what it said. But you had to figure out how to do that. So I'll be telling you what we did to operationalize that requirement. And then the last, the current funding that we're just starting on is the Canadian Consortium on Neurodegeneration and Aging. The funding is just coming right about now, very soon. And so I'll come back to this at the end in terms of our future directions. So that's kind of the big picture of our funding over the years. And now I'll just say a little bit about community-based participatory research as an approach. It's rooted in the work of Kurt Lewin from the 1940s. It's really based on action and change. It's more of a orientation than a strict method, and involves equal partnership and influence from both groups, the researchers and your partners. And it focuses on issues that are important to communities and brings together people with diverse skills, researchers and community members and so on, for addressing complex health problems. And I think that, health service delivery for dementia in rural settings would qualify as a complex problem. Israel et al. Identified some principles of community-based participatory research, and I put this here just so that you can kind of keep these in mind as I'm going through the presentation to see whether we're doing these things, recognizing the community as a unit of identity, being collaborative and equitable, that there's action that benefits all partners. A lot of times research is is maybe more useful to the researchers than the partners. And this is not the case in a true community-based approach where there's co-learning and empowering. It's cyclical. It disseminates findings to all partners, not just publishing your research in a scientific journal that might not be accessible. And it involves long-term commitment. And these are, it's a continuum, I guess. It's not all or nothing, this type of approach. A decision maker, I'll use this term a lot, decision maker, stakeholder. CHR defines this as anyone who makes decisions about or influences health policies or practices, and someone who is likely to make use of the research. So this is a very broad definition. It includes patients and families and so on, policymakers, health service providers. Knowledge exchange is a term that you, I'm sure, hear a lot about. This definition is the Canadian Health Services Research Foundation. Knowledge exchange and integrated knowledge exchange, I think that these are sort of terms that the health funding organizations like CHR have their way of operationalizing the community-based research approach. It's not theory-driven, I guess, but it's more practical, technical. These are is how these funding agencies want researchers to engage with communities. So CHR doesn't really talk so much about community-based approaches as they focus on integrated knowledge exchange, and they expect this to happen throughout the research process. You know, in the old days, you did KT at the end of your grant. You wrote a paper and you published it, but you didn't engage your partners at the beginning, which is what integrated knowledge exchange is about. You're starting at the beginning and all through your research. And some of the benefits of using an integrated approach are that the decision makers are identifying the priorities and working with researchers working with decision makers in the communities means that the research will be better quality, it'll be more relevant and useful, and you'll see more application and uptake then because they're involved. You're looking at issues that are important to them and they want this information. And we learn about each other's worlds, it's just very different, very challenging on many, many levels. So it's not always easy, but it's very important. Oops, I'm doing something wrong here. There we go. I wanted to include this slide of Arnstein's ladder of citizen participation. And Arnstein is trying to be deliberately provocative here. This was published in 1969. It's actually available. If you Google that, you can find the article. Starting, you know, at the lowest level, manipulation, informing, consulting. I think sometimes we think engaging communities involves just consulting with them, but actually that's not very far up this hierarchy. And at the top, well, you see partnership, citizen control is what Arnstein proposes as the top level, where the citizens are actually in control of the research. And there's a lot of challenges to that, including, you know, the fact that researchers have to be accountable for the funding and so on. But just something to think about. I had a reviewer recommend this paper when I submitted an article, and I'll actually give you a reference for a paper that's coming out that I was told I should reference that, and so I dug it out. So as I mentioned in the applied chair funding that we got in 2009, we had to involve decision makers early and often, which was great for us because we were already doing that. But we operationalized that by developing a decision maker advisory council. We started out with 27 members, and we knew a lot of people because of our community-based approach that we've been using up to that point. But we didn't actually have a formal decision maker advisory council. But we had a lot of relationships, and we knew who to draw on from the community and long-term care and policy and families and so on. So this group has been involved in informing and guiding our research since 2008, and in doing all of these things, including developing policy implications, which I'll give you an example that we just did a few weeks ago. So these show the individuals or the types of people that are on our Decision Maker Advisory Council right across the spectrum, from healthcare providers and the Ministry of Health, the Alzheimer's Society, Health Quality Council, healthcare providers. And what I'm going to try and focus on today as I go along is some of the things that have contributed to the sustainability of our community-based approach and our research over time. And partnerships are really the core of that, including, with the Alzheimer's Society, the Ministry, the Health Quality Council, health regions, other researchers internationally. We have a very strong team. We have fantastic student involvement, and we've had funding, and we've had really good institutional support from the university. This is a paper that's just got a email this morning to sign the, author, I forget what they call that form, but anyway, this is coming out in the next issue of Progress in Community Health Partnerships, and describing really what I'm telling you about today. So this paper will be available before too long. So I want to tell you a little bit about our rural and remote memory clinic, and I'll come back to all of this on the bottom, how it works. But the goals of the rural and remote memory clinic, which was we call it our flagship project for our first team grant in 2003. We developed this and evaluated it because everyone on the team was involved in that. All the investigators had their own spin-off projects of their own in physical therapy and medicine and psychology and so on, but this brought us all together. So it was very important for being a team. And before we started that clinic, we spent the first year traveling around the province, visiting rural and remote communities and meeting with healthcare providers. We wanted to develop the clinic. What would this clinic look like, and how would we evaluate it? What kind of a research design would we use? So at that time, in 2003-04, there were 14 rural and remote communities that had telehealth. There's a lot more now. Basically, it was one per region then. So this, we would have had a lot more places to go. But as it was, I think we traveled 7,000 kilometers visiting with healthcare providers in these communities. And we went to the north. Some of them we had to fly. But this year was really important for us. We met a lot of the people that we are now working with and who would be using the clinic. What we learned was that our idea of using a randomized controlled trial to evaluate the clinic would not work. We wouldn't have good stakeholder buy-in. If we took those 14 sites and only assigned 7 of them to not get telehealth, even though they had the telehealth infrastructure, that they wouldn't be happy with that. So we decided, after a lot of debate in our team, to use a single case design. So all 14 sites get to use their telehealth. The individuals alternated telehealth and in-person, so they could compare their experience within themselves. So that helped with the acceptability of the intervention. We also found that in the north, the healthcare providers that we met with said even alternating, having patients drive back to Saskatoon every other time for their follow-up appointments is not feasible. We won't even refer to you, because why start the process if our patients can't follow through? Getting to Saskatoon from these communities is very difficult. So we decided to treat these as a separate sub-study. We offered them telehealth for all of their follow-ups from the beginning, which is different than the rest of the province where they alternated telehealth and in-person for the duration of the research. So, this was really foundational for our research to have this input, and we only got that because we were out there talking to people. And I'll just mention that because of those community visits, these 3 student projects developed that weren't originally planned, but because of our experiences in the north and the challenges of dementia care there, we had 3 student thesis projects that focused on issues in dementia care in northern Saskatchewan. So another, I guess, a benefit of this approach. So we had all that input into the clinic. So I'll just tell you briefly what we do in the Rural and Remote Memory Clinic. It's quite unique. I'm not going to say there's not another one out there, because there might be that I don't know of. But before the memory clinic was developed, individuals needing a diagnosis had to travel multiple times to Saskatoon, maybe see the neurologist and then go home, and then maybe come back and see a neurologist, and then come back again for a CT scan, and then come back again to have the neurologist interpret all of that and tell you what your diagnosis is. That can take a lot of time and a lot of trips. So we wanted to streamline it into a one-stop interdisciplinary clinic where you get everything on one day and go home with a diagnosis. So we start up with telehealth, doing a pre-clinic assessment with the nurse and neuropsychologist, so that we know what the problems are before they get here. We can tailor that day to them. And it's a family-centered clinic. People with dementia, we need their families here to help us with history and so on. It affects the whole family. And then when they come a few weeks later for a full day assessment, they see a whole interdisciplinary team. We start out in the morning where the patient and their family meets with everybody on the team, so they don't have to tell their story 10 times to different people. They see all of these specialists. They have a neuropsychology assessment, which is 2 hours. They have a CT scan. And then at the end of the day, our team gets together and we talk about what we all found and what we think the diagnosis and treatment plan is. And then we meet with the patient and family to communicate that to them before they go home. And then we follow them up using telehealth, so they don't have to drive back to Saskatoon for a 15-minute follow-up appointment with the neurologist, Dr. Kirk. Originally, during the research, we alternated these, but we learned very quickly, really, that people wanted to do this by telehealth. It saves a lot of travel time, cost, hassle. And then annually, we see people face-to-face again if they're not too advanced and are still able to travel. We bring them back for a shorter assessment in person. And since the clinic started in 2004, we've seen it'll be a little over 460 people now, and we see them from all the health regions. So it began as a research demonstration project, but now it's funded by the Ministry of Health for the clinical component. The research part of it is still up to us to get the research grants, and we provide the space. But this transition from research to a sustained program is not an easy process. There was an article that came out in the Canadian Medical Association Journal in 2009 as an editorial, Canada, a country of perpetual pilot projects. This is what happens often, is that you design a great intervention, it works, but then you can't get it sustained, and it ends. So we worked very hard. We spent probably a year and a half trying to get from the research to a program. I think what helped us was having our Decision Maker Advisory Council. There was a lot of people who knew what we were doing and recognized the need and were supporting us. We had Ministry of Health and Alzheimer's Society representatives on our Decision Maker Advisory Council, so they knew and could help lobby and on the inside, because it's very hard to know how these decisions are made. It's not very transparent. So having people who are inside and have better connections than we do is very helpful. So we were really pleased when this happened, because it doesn't always happen. I'll just give you a few pictures of our clinic. We used to be in an old house on College Drive, and then we got moved to the dentistry building, and we made do with that space, but then we got to design new space with the architects in the new E-wing, and we're near the library by the old main elevator, so we actually have signage now. I put that RRMC on there, where we have a separate entrance right beside the main door, and just our waiting area, and our clinic nurse, Leslie Holfeld, and Drew Kirk and one of our family rooms. We have 2 rooms where the family gets to spend the whole day, because they're there all day. We wanted to create kind of a more home-like, less institutional kind of setting. And this is Dwayne Minish, our psychometrist, and we have 2 testing rooms and an exam room with Dr. Kirk, and there's Julie being a model patient for us there. And again, in our research room in the clinic, we have telehealth capability. That's Leslie, our research nurse, our clinic nurse, and an end-of-day team meeting where we discuss the diagnosis and treatment plan before we meet with the patient and the family. So that was really our main project that we did with the NET grant. There were a lot of other projects and student projects too. But when the NET grant ended, we then were funded by the chair. And as I mentioned, this applied chair program required decision maker involvement. And so we developed a decision maker advisory council. And when I invited those people to be on that advisory council, I talked to them about, well, how will we work together? And everybody agreed that we needed to be face-to-face sometimes, at least once a year. I mean, twice would be better. And these are rural people who have to drive a lot, still felt we needed to get face-to-face. So we decided to start what we call a summit. It's a decision maker, it's a knowledge exchange event. We have an evening wine and cheese poster session and then a full day knowledge exchange meeting. And it brings together the advisory council, our research team, and then other people who are interested. So it started out with about 50 people. This year, I think we had 65, and we had to turn people away. We just didn't have room. So there's a growing interest and awareness, I guess, about what we're doing, and it's rewarding to see that interest. The goals of the summits are really knowledge exchange between and among the researchers and the decision makers. It's really exciting to see all these people coming from all over the province, the healthcare providers, families, health region administrators, all talking to each other. And the informal networking part is what is evaluated very highly. We have to, if we make the coffee breaks and lunches too short, we hear about it because they want to talk to each other. We update current projects and plan them, and we figure out where we're going in the future at these summits. So this year, our last summit, Summit 7, was just last month, and we had our evening wine and cheese poster session. It's informal. We have a bar and nice food, and people really enjoy getting together and reconnecting and looking at the research and getting warmed up for the next day. And then we have a full day knowledge exchange meeting. We usually have a keynote speaker. This is Dr. Anthea Innes from Bournemouth University in England, who is one of our co-investigators. And Julie and Jacqueline Quayle from Health Quality Council presenting on the Radar Health Quality Council gap analysis report that I'll tell you about. We just finished. And then we have working sessions. It's not a conference where you go and sit there. People work pretty hard at these meetings. And that's what it's about. So besides having these annual summits, we've also had other knowledge exchange and decision maker meetings. And one really key one happened in 2011. We were planning a CIHR grant called Community-Based Primary Healthcare Team Grants. And we had a planning grant from CIHR to plan the grant. And we had 75 people come to a day session where we wanted to identify the research priorities for primary health care in dementia. And this work, this as informing what we're doing today. Even though that grant was not funded, that work that you do with your decision makers and the planning it's not wasted. It might feel like it for a few days after you get the rejection, but so we invited international guests to come and present. We had two clinicians come from Scotland. They provide a remote telehealth dementia diagnostic service from Aberdeen, where there's a geriatric psychiatrist, to the Shetland Islands, where a dementia nurse they do diagnosis by telehealth. So they came and talked to us and got everybody really excited before they had to get down to work. And then I got to go to the Shetland Islands too. That was really cool after that. Yeah, it's a beautiful place. So this just shows some of the working going on at the October planning meeting to plan the team grant. And one of the things that we asked the focus groups to do in the morning was to identify the gaps that they saw in primary health care for dementia, the reasons for them, and how they could be addressed. And then in the afternoon, those same groups worked carrying that on to draw out what they saw as an ideal model of dementia care. And so we had about 5 or 6 of these. And then we analyzed all of the work that went on all that day, and we followed it up with a retreat the following June to continue the momentum with a little bit smaller group and really finesse, I guess, the research proposal. Dr. Innes came from England, and all of that got written up into a report that's 100 or so pages, Julie. This report is on our website, and it's a wealth of information about rural dementia care and primary health care, and we draw on this for our work still. And one of the things that we did in planning that grant, even though it wasn't funded, Sun Country Health Region said they wanted to partner on that ground. If we were funded, we would do our research there. Well, we weren't funded, so what happens then? They had gone ahead and very confident that we would be funded and decided to make dementia one of their regional priorities, or HOSHNs, using the lean language. So they had this dementia HOSHN. They had actually a part-time person budgeted to do the work. We didn't have the grant, but we decided to carry on with them and work with them, and they with us. And that's because we had a long-term relationship with Sun Country over the years at the summit. There was a lot of trust there and commitment on our part and theirs. So in their HOSHN, they wanted to build their capacity of their healthcare providers to provide dementia care. So we committed to supporting that. And one of the ways that we did it is that we came together in a working group with Sun Country and the Alzheimer's Society, which at the same time was implementing a new First Link program. They got money from the ministry to have 4 new regions that had a dementia First Link coordinator and a resource center, and they were rolling that out at the same time that we were starting to work with Sun Country. So we got together these 3 organizations, and it's been really fantastic because this group has 3 functions. For Sun Country, this working group supports their dementia HOSHN. For the Alzheimer's Society, it's their dementia advisory network for the First Link program, which they have to have. And for us, it's our regional advisory council. So it's really productive for everybody. And the ways that we're supporting Sun Country with their HOSHN is being part of their working group. We did an analysis of dementia incidence and prevalence in Sun Country, and we looked at the availability of dementia services in the region. And we did a learning needs assessment for their home care staff. And as you know, with Lean, they need metrics and numbers to put on their wall walks and all the things they have to do with Lean. And so we were able to provide that to them, which was a huge benefit because they don't have a lot of the resources and skills that are needed to do the research and so on. So it was a good partnership. And the learning needs assessment we just completed, and there's a report that we finished in July. And Julie and I were in Sun Country this fall and met with their home care directors, and they are going to be designing a education intervention based on the results of this study, what the staff said were their learning priorities and needs. So we did this even though we weren't really funded to do this. We just used our existing resources to do this because they're our partner. Oops. Going forward here, there we go. Another key partner is the Alzheimer's Society of Saskatchewan. They actually funded part of our new emerging team grant in 2003, and they're involved in almost everything that we do, which makes sense. They're one of our key, I guess, users of our research, which they are trying to deliver programs and services for dementia in Saskatchewan. The Alzheimer's Society, as I mentioned, has recently implemented these First Link resource centers in rural areas, which is wonderful. And in each of those 4 rural regions, they're going to develop a dementia advisory network of healthcare providers and families that is going to get together and examine dementia care in their region, figure out what the strengths are, where are the weaknesses, what do they need to do to improve care in their region. And the summit that we have every year will be the annual gathering place for the Dementia Advisory Networks. They don't really have a venue to do that, so it makes sense for them to get together at our summit and at the same time be able to report to the summit attendees each year who come from all over the province about what they're doing, what's working. It provides opportunities to learn about successful innovations and scale them up across the province. So we're quite excited to be part of that. Another study that we've done that has a big community-based partnership approach is led by Dr. Megan O'Connell. And I'll just mention that, the summit provides oversight and guidance to our whole research program, which is made up of a lot of, smaller studies. And most of those smaller studies have smaller advisory groups as well. And for example, the work that Megan O'Connell did, along with Dr. Margaret Crosley, who was our first memory clinic neuropsychologist, and now Megan is, was to develop a telehealth support group, which is a novel intervention. Megan is the director of the Vital Lab on campus. It's a CFI-funded lab. She's using video and telehealth research. And the way that this group started was that in our memory clinic, we were diagnosing atypical dementias. That's our focus, the complex, difficult cases, not so much the Alzheimer's disease. And we were making diagnoses of frontotemporal dementia, which hits people often very young, 40s, 50s, 60s. Very different needs for patients and families than a typical Alzheimer's, which is more late 70s. So we realized that they had needs that weren't being met. There was nobody in their communities to support them. The Alzheimer's Society had no programming. So they developed a telehealth support group where they got together once a month. This is still going on. And they would see each other on the screen, all their faces all at the same time. And it works really well. The members of that group joined us as members of a support group, but they were also agreed to be research partners in the research and to help us develop and evaluate a template for telehealth intervention. So they had a dual role, really. And as a result of this program, these members became like super advocates for spouses and families of frontotemporal dementia patients. And sort of dragged us all along with them. Even though we don't know much about advocacy, we had to sort of learn to support them. And now the Alzheimer's Society is actually delivering 3 support groups by telehealth now all across the province. So this is another example of uptake of research that doesn't always happen. And I think one of the things that made it happen was that in 2010 at our 3rd summit, 4 members of the frontotemporal support group came to our summit. They, and this is Megan O'Connell, presented on their experiences in trying to get help and support for their family member. And it was an incredible presentation. People had no idea of what these caregivers had to go through. And the Alzheimer's Society was at this summit, which they always are. So after the summit ended, at the end of the day, they got together and talked. And I think that really, the Alzheimer's Society realized that, there was a gap in their services and that there was something they could do about it because our intervention, they had the data, the results. We knew that this telehealth support group worked because they were involved in it. I think that played a role. The participants at that summit said, that was an incredible presentation that those support group members gave. You should have been videotaping that. Well, we didn't. We had no idea what it was going to be like. But after that, we did. So we were able to use our grant resources to work with EMAP on campus. And the panel members came and did their presentations on video. So I just downloaded this week. You can see Donna's story has had 13,000 hits. Ernie's story, 11,000 hits. And And Donna, I just showed you, she presented at our summit in 2011. Her husband had early onset frontotemporal dementia. She realized that he was very agitated a lot of the time, but if he had something to do, an activity that he could do and succeed at and enjoy, he was a lot more settled and calm. So she developed a whole activity program that she presented at Summit, and you can see all her props here. She really stole the show. It was really fun and interesting. Again, she's been invited subsequently to present at a lot of nursing homes now about this program. But we also asked her if she would be willing to do a video about her activity program. So this is also, it's available on YouTube or on our Rural Dementia website or at the Canadian Centre website. These videos are all available. So these caregivers would never have done these things without involvement with the researchers, and we wouldn't be able to do this without them. I think this was empowering for them. It was scary too, because they had never done public speaking. Donna was a teacher, so she was more comfortable, but many of the panel members were not, and it was, they overcame those fears, I guess, because they felt so strongly that there was a need for what they had to say, and they wanted to get their message out and to know, for others in their position, to know they weren't alone. So it's, I guess, the empowering part of participatory research. Maybe this is an example. Shonda Lanting was one of our early doctoral students, and her work developing assessment protocols for Aboriginal seniors also used a community-based approach over 4 or 5 years of engagement. And she started out in Saskatchewan working with an Aboriginal grandmothers group, doing focus groups to identify how we could modify our current assessment protocols, the neuropsychological testing. And then she did field testing in northern Saskatchewan, and then once that pilot testing was done, we were able to use those tools in our clinic and gather normative data. So it was a very nice process. And some of the things they learned in doing this was cultural context being very important in developing tools that were engaging and would provide a more accurate assessment of cognitive function. Because if you give a tool, use an instrument with someone, like using the mini mental test, for example, it's not culturally appropriate and relevant. If people score poorly, then you might assume, well, they have dementia, but it's really the problem is with the test not being valid. So they learned about color, humor, using natural images. This is the actual Bushke cued recall test. It's black and white drawings like this, very boring. But what the modifications that were made that used color, imagery, more relevant images and so on, it's the same test, only better. And this is the pyramid and palm trees test of semantic memory. And again, this is what the actual test looks like. It's tests the associations between words and images and meaning. So you have to match up the image at the top with one of the bottom ones. Any idea what goes with what? The clown with I think it's the lion, yeah, because of the circus, yeah. Good. And this is another one from the original test. You see, church, yeah, okay. So this is what one of the many examples that Shonda came up with in her research to develop the new test that's called Grasshoppers and Geese. And it does have pictures of grasshoppers and geese in it. But so what about this one? Yeah, okay. And I think there's one more here. Yeah. So again, all of this came from years of working with communities to develop these tests that we use in the clinic. And Margaret Crosley, who was Shonda's supervisor was developing also a screening test called the NCAM, or Northern Cultural Assessment of Memory, and she, with her students, flew up north on Northern Medical Services flights twice a year for 4 or 5 years, worked with Northern community members in home care to develop and test the NCAM tool, which uses familiar objects and so on that have to be, manipulated, remembered, and so on. So these objects, again, are much more culturally relevant than a lot of the existing testing that asks about, who's the prime minister, and a lot of questions that really aren't very meaningful. So another partnership, and I've referred to this a few times, is with the Health Quality Council. And we're just finishing up a report that we've been doing over the last couple years with them. And the objectives of this study are to compare actual to best practices in dementia care. So we're looking at the gap between what are the best practices and what's actually happening. Because in Saskatchewan, we really don't have much data about dementia care practices. We don't even have, we only have estimates of dementia incidence and prevalence. So our gap analysis has 3 components. We did a best practice review of international dementia plans, and we did an administrative data analysis looking at incidence and prevalence of dementia. And we did a scan across the whole province, every region, looking at existing services for dementia and their fit with primary health care principles. And this is all guided by a steering committee. And just a few weeks ago, there was a story about the report on the Health Quality Council website. So one of the advantages of working with the Health Quality Council, not only they have the expertise to do the administrative database analysis that we don't, they have access to the administrative health databases that we could, but it's very difficult. They also have the connections, with our health clips, and when our report is finalized, it's actually just with the ministry for approval now, then it'll go on their website, and so having a partnership with them has a lot of benefits. They have skills that we don't, and vice versa. For example, we're the content experts that Health Quality Council doesn't have, but Jacqueline Quayle, who's our analyst there, knows the databases and the programming and has access to the data. So it's a great partnership. And I just want what I want to say about this slide is that the methods, the instruments in this study that we used for the environmental scan part, where we're looking at services, all of that was developed over a couple of years through our summits. Every year at our annual summit, with some part of that work was working on this project. We had a steering committee, and the whole idea for it actually came out of that October planning meeting in 2011, where Tanya Verrill, a senior researcher from the Health Quality Council, was there and said, she brought us this Spotlight on Dementia Care. It's a UK report, and said, we could do something like that here. And that was the start of it. And now, it takes a long time, but that was where it began. So our partnerships with the communities and the Health Quality Council and our with Summit and so on have really been productive. And this report that we're releasing now on incidence and prevalence in Saskatchewan is the baseline data for our new study that we're just getting started on. And just an example of the work that happens at Summit. Last month, we had finished the report. We wrote draft recommendations. We had 10 recommendations for policy research and practice and knowledge exchange. And so the group at the Summit had the task of reviewing them, revising them, ranking them, and developing an action plan for those recommendations. So we presented the report, and then they worked in small groups to take them and work on them. And now we've made those revisions, and it's with the ministry. So for us, having 65 people working on those recommendations, we feel a lot more confident that we're getting them right. And so just in terms of future directions, our new project that's just getting underway is the Canadian Consortium on Neurodegeneration and Aging, which is really, I guess, the result of a lot of work that we've been doing over the years, leading to primary health care research, which is a new area for us. The CCNA is a huge $31 million project. There's 20 teams from across Canada in these different theme areas, and there's about 6 or 7 teams in the quality of life theme area, and we're one of those. We're team 20 of 20, so last but not least. There's investigators, 340 investigators in CCNA from across the country. The leads are in different provinces, but all the teams had to be cross-provincial. You couldn't just be a provincial team, so we have members from 4 provinces in the UK. It was formally launched at McGill in September, so it's just getting going. So what's different about CCNA is that it's bringing together our radar team and another group that's our leaders in Indigenous dementia care. And there's some overlap in the issues and so on, but they're not identical. So we are doing similar kinds of research, but not identical. So we're actually got together for the first time last summer in Saskatchewan and working on our proposal. So we have projects in each of these 4 areas, but our projects are a bit different. We've had a number of meetings in Toronto and Montreal of the full CCNA consortium group to plan all of this, 20 teams, platforms for blood bank and imaging bank, and it's going to take a long time to get everything up and rolling, but being part of the Canadian Consortium initiative is quite exciting. And but you know, there's new challenges of communicating, because we now have our team is twice as big as it was, 23 people. We are, I think, 11 cities and 4 provinces. So in June we had a video conference. We had 5 different sites on the video conference to have meetings, and we actually got together last summit in October. We had a face-to-face meeting, and we had our picture taken. And I won't go into our projects really too much because of our time, but the rural stream is funded by the Saskatchewan Health Research Foundation. We're focused on primary health care because this is where the majority of care has to take place in a rural area. Our specialist clinic can help with the really difficult cases, but we don't really know how to translate the best practices in primary health care into rural settings. So that's what we're doing. And we're just espousing, I guess, what work has to say about rural areas being change agents and innovative and great places to do research and evaluation, and not just being in deficit. You think of rural not having this and not doing well at that, but it's actually, they are very innovative. And not surprisingly, our approach is a community-based approach where we're going to be working with teams, primary healthcare teams, to take best practices and figure out how we do that with them in rural settings, and how different rural contexts affect what you do and what works and why, because rural communities are all different. They're not homogeneous. And we have 3 main projects led by me and Dr. Julie Costinet and Dr. Megan O'Connell, looking at standardized care pathways and how our specialist team, the memory clinic, can support primary health care providers because they say they need these tools and these pathways and this support to do better dementia care. And then the Indigenous stream, led by researchers in Ontario and Saskatchewan, and some of this Indigenous dementia research stream research will be done in Saskatchewan as well. And they have also 3 theme areas led by different investigators, and I won't go into that. And I just want to end by saying I'm not going to go into all the student projects, but having a team like this with 10 years, we have a very long we have a 10-year database from our memory clinic with data from patients and caregivers from all the different disciplines in one database. It's a rich resource for students to do their thesis projects, or else they can engage with patients and caregivers for their research. So there's lots of opportunity, and we have some really great students doing really interesting projects. And there's some more. So, we're very fortunate to work with these great students. And I'll just end with this slide. You've probably seen this before. I see it around, but I think I showed this at our first summit, I think, in 2008, and I still think that this is a great summary of doing community-based research. It does take longer sometimes to work with communities and partners, but you get a lot farther together. Thank you.
Good afternoon, everyone. We want to thank Dr. Morgan so much for her very interesting presentation.
Thank you.
I personally admire the work that you're doing in this area. It's quite intensive and quite comprehensive as well. And I'd like to start off the question and answer segment with one question of my own. And you mentioned in your presentation that transitioning from research to a sustained program is quite challenging and difficult, but somehow you managed success in this area. Could you just highlight a couple steps, a few steps in how you were successful in getting this done?
I think the idea of focusing on research questions that are of interest to others, other organizations or health care providers or service providers is really important. And making sure that they're involved from the beginning, then they have input into what you do. And engaging with them very early. One of the lessons, and I didn't say this, but with the frontotemporal dementia telehealth support group, one thing that we didn't do was engage the Alzheimer's Society from the very beginning. So the telehealth intervention was developed with the support group members, spouses of our memory clinic patients and our neuropsychologists, but we didn't engage the Alzheimer's Society, who if we'd thought ahead, are our natural people to take that on once the research is done. And so we did make that transition, and they are now doing it with our help. So Dr. O'Connell is actually involved in those support groups that the Alzheimer's Society is delivering. She's there, she's still doing it with them, and eventually the hope is that they will feel comfortable to go on their own. But I think they would get there a lot sooner if they had been actually involved from the very beginning instead of a few years later when the research is done and we have this intervention that works. I think that their capacity to deliver that program and be comfortable and so on would have been enhanced, and if it had started earlier. So that's I think a really key lesson is to think about who you want to take over and use this program and implement it and sustain it, and have them as your partners from the beginning.
Thank you. Very good. Do we have any questions from the audience? Sure. Remember to press your button.
I was wondering about your initial research with the Rural Dementia Clinic, and when the patients come in for their full-day appointment, did you have any patient fatigue issues at all?
Yeah, that's a really good question, and yeah, it's a long day. It's a tiring day, and we actually, for the first 100 patients that came to the clinic, we did a post-clinic telephone interview afterwards, usually with the caregiver, but sometimes with patients too, if they were early on and were able to take part. And we did touch on that. It's they have to get there. Often they come the night before. And stay over, and then because they have to be there at 8:30 in the morning. So what we have heard is that yes, it is a long day for everybody, the family and the caregiver. But the alternative of making 3 or 4 trips and having this spread out over months and months is more tiring. So the trade-off for them, at least for the majority, I think, is that they would rather have this very full day than to the alternative. Yeah.
Thank you so much for the presentation. I really like what you are doing with the communities. And I think there should be also some challenges about working with communities in the participatory research. So I would like that maybe you can explain what main challenges have your team encountered in the process of getting connected with the communities for research.
Okay, so there are challenges, and I've alluded to some, but I think I focus more on the benefits. Challenges, I think you need to identify partners that are enthusiastic about what you're doing, because it takes a lot of time for them to be involved in working with us. And over time, I think we all feel like we're all getting busier and busier, and so are they. Like, for example, the health region people that we work with, home care directors and so on, and primary health care, everybody seems to be more and more busy. And so for them to work with us, that's time they're not doing something else. So that's a challenge. Synchronizing the work and the balancing their needs with ours and so on is sometimes a challenge. For example, Sun Country got all excited and made dementia a priority to focus on, and then we weren't funded. We were able to work that out by continuing on with them, but sometimes synchronizing their budget cycles and ours, and the fact that not all grants are funded, but you have to have partners to go forward to submit it, and then if you're not funded, then you have to figure out a way to maintain those relationships, because if you don't, then it's hard to go forward again for the next grant without a partner. So they have to trust you that eventually you'll get funding, because we're not always successful. So those are challenges. Julie, if you think of anything, other challenges, I'm sure there's, yeah. That's a really good point. The travel, and you have to do it. I mean, you can't always expect people to come to you. So, for example, Julie was adding up the other day. We've had a lot of teleconferences with Sun Country since we started our working group in a little over a year ago. But we have actually gone down there 6 times since last July, and we've traveled like 5,000 kilometers. It's a big time commitment and money. I mean, we have to go the night before because it's like 7 hours to some of these communities, and you can't really go there and do work and come back the same day. So there's costs of travel. So those, that's time you're not doing other things like writing publications and so on. So it's a big investment and a commitment.
You mentioned that synchronizing different people's priorities was a huge challenge, and I was wondering how you were able to overcome that.
Oh, how did we overcome it? Well, I guess there has to be a lot of give and take. You have to be able to share the control and the power, and over the long term, you learn, you get to know the people that you're working with, and for us to continue working with Sun Country for over a year and using our existing resources to do research there, even though we didn't have new money to do that, that shows our commitment, and we're getting through some of the lack of being synchronized, I guess, where they were ready to go forward and we didn't have the the funding to do the main study that we wanted to do, but we were able to do something else that was important to them. So we did the learning needs assessment and the gap analysis and so on. So it wasn't the primary healthcare research that we're going to do now that we finally are funded through CCNA to do that. We were able to do some smaller projects. So we didn't just, say, well, sorry, we can't do anything. We identified what we could do with the time and the money that we had. So I think that those are some of the ways that you can get around those challenges. And we've been, fortunate to get meeting grants and so on. Over time, now that CIHR, for example, often requires community involvement, you are able to apply for meeting grants and development grants that are specifically to help you engage with your decision makers. So we've been able to access a number of those grants. So that helps with the financial side of things, because these are rural people who live in rural areas, and travel is expensive. So to come to a meeting here for our summit or our October planning meeting, you have to be able to pay for travel and hotels and meals and things for people. So getting those extra little meeting grants and so on has made a big difference.
Well, I have a question. Thanks, Deborah. That was a wonderful presentation, really relevant. I'm thinking about, I've got a few questions. But one is about including the patient in your research, because you've got a challenging patient population to work with in terms of dementia. But how have you done that? And alongside that, can you talk about the fact that dementia would be only one aspect of what might be going on with patients? You cite the fact that many of these patients are in their 70s or older, because that's when dementia is most likely to be common. But you've got patients that also have multiple other chronic health conditions, and how that impacts on their potential involvement, and how you think about the research that you do, because you're working with patients who have complex needs. So the first part is about including them, and then about how you deal with the fact that they have many issues.
Yeah. So in our Decision Maker Advisory Council, we have several family members who are our patient advocates, and we don't actually have a patient on our Decision Maker Advisory Council. We learn a lot about patient needs through our memory clinic, because we spend whole days with patients over the years. But in our Decision Maker Advisory Council, we are relying on family members. And one of our family members, interestingly, was also a director of home care in a rural health region. So she was able to bring both the perspective of having a husband who was actually a memory clinic patient, and then who ended up in long-term care. And so she brings a great perspective, because she's seen from the early stages to long-term care across the whole spectrum, which we are also interested in. And then what it's, the hat of being a healthcare provider, a nurse and an administrator at the same time. So I think if you get an early stage dementia patient, someone like that really could probably be involved. And we just had evaluations from our memory clinic recently, last month, and that was one of the suggestions that one of our speakers be someone with dementia. In terms of the comorbidities and so on, that's very true. These are older patients that come to our memory clinic. One of the reasons that we do the preclinic assessment is that we're able to get a sense of what those might be and how we need to adapt our testing during that full day to their specific needs. Do they have mobility problems, hearing problems? Sometimes we have something called a pocket talker that helps people with hearing impairments, and of course we rely on families very much because of their cognitive impairments. And often people with dementia do have multiple comorbidities that make the diagnosis more complex too. Differentiating depression and dementia is very challenging, and I think sometimes the referrals that we get in the memory clinic are really related to that. Family physicians having not being confident that they're able to tell whether this is a problem with dementia or depression. It's true, I think, more and more that we can't think of dementia in isolation, but to look at the impact of comorbidities. And one of the teams that we're working with the new CCNA, there's 20 teams. One of them is looking at comorbidities in dementia. How does that affect the risk of getting dementia and the trajectory once you're diagnosed? And so we are going to be working with that team led by a geriatrician in Halifax. And we hope to do some administrative health database analyses with the Health Quality Council, and she's going to be doing that in the Maritimes and looking at how comorbidities affect dementia. So it is recognized as a big factor in being a risk and how what happens after diagnosis. Yeah.
If there are no more questions, once again, we'd like to thank Dr. Morgan and her team for sharing with us this afternoon. A round of applause, please.
Thank you. Thank you very much. I enjoyed it. Thank you.